Thank you for joining us on Politics of Money, the official podcast of the IFSD. And as usual, I am joined by my fellow bald people. We have our chief economist, Dr. Mostafa Askari, and live from Thunder Bay, Ontario is Kevin Page, our CEO. My name is Sahir Khan. This is the first of a series of kind of pre-budget podcasts. The budget is going to be tabled sometime this fall, and a number of issues are kind of obviously front and center, and we certainly know about defense, security, the economy, trade. But there's an issue that just never quite goes away in Canadian politics, and that's healthcare. And we have the Canada Health Transfer due for renewal in 27-28, and some of the bilateral agreements are up for renewal next year. And so all of a sudden, the premiers and other important stakeholders are raising issues around healthcare and how it fits in the whole fiscal situation and really this kind of budget squeeze that Canada's now kind of dealing with. So wanted to kind of get the conversation started, Kevin. Healthcare, major structural spending pressure, also really important for the economy, well-being of Canadians. How does healthcare fit into the hinge moment, the agenda, the priorities? Might not be front burner in the news every day, but never too far from the hearts of Canadians.
Yeah, I think that's very well said, Sahir. I think that when we saw the platform from the Liberals in the spring of 2025, that like healthcare wasn't front and center in terms of the hinge moment. The hinge moment being a moment where decisions we're making now are going to have a long-term impact. We find ourselves, according to the Prime Minister, and I think we would all agree, a world that is changing, a world order that's changing, significant wars in Europe, in the Middle East, the potential for conflict in other places, including the South China Sea. We find ourselves in trade arrangements that are, agreements that are no longer being honored with these higher defense, demands on Canada, and just some weak productivity issues that we need to make some big decisions. So, but I think healthcare was presented by Prime Minister Carney, in the budget of 2026 as something that can contribute, but something that played a more supporting role. I think that where some of my colleagues, our colleagues, people like Jim Stanford, I was at the Premier's meeting with, I think they see it as like a big industry, a $400 billion industry that contributes significantly to growth, to productivity, to research, and is, export resilience. If you look at, the size of the labor force, it's, again, you look at innovation dollars, it's, all these, like, it's a big sector of our economy. I think the Premier certainly see it as a unity issue, and so, yeah, it's not going to go away. So,
Mostafa, where does healthcare kind of fit in terms of the overall fiscal situation for the federal government? It's the delivery is clearly a provincial responsibility, but the federal government makes important contribution, has through tax points and through current expenditures. The pressure, particularly with demographics, never goes away, or at least not for the foreseeable future. So how do we get through some of these challenges, and how does it fit into the fiscal structure that we have?
Well, right now, it's the second largest item in the government program spending. I mean, probably in the next couple of years, defense is going to take that over. Health becomes probably the third largest. But it is a large item in the government program spending. It grows every year based on the escalator that we have right now. It is 5% until 2027-28, and after that, if there is no change in the agreement, it goes back to the average of the nominal GDP growth over the previous 3 years, which is going to be around 3.5% to 4%. So that's part of the budget. And it grows significantly, and by 2030-31, it's going to get close to $85 to $90 billion. Now, overall, in fact, actually, the federal government transfers about $115 billion to provinces in different ways. And one of them is social transfers, one of them is health transfers, CHT. These are the biggest items in there, and then equalization. Those three actually is about $100 billion a year. So, and that money goes to provinces. They can use it in any way they wish, because there is no targeted funding here, although they called CHT, they called social, but the provinces can use that money in any way they are shaped they would like to see it and they fit in their budget. So it is a big item, and any change in that, whether there is a change in escalator or a change in the base or any other change, obviously has a huge impact on the government budget and the bottom line.
Look, Kevin, as Mostafa said, large amount of federal government spending are transfers, and we've seen that accountability for results often suffer with transfers, in that you've got one order of government kind of raising money and another order of government spending it, and not a lot of levers kind of in between to kind of hold that spending to certain targets with respect to results. In this renegotiation or the next round of renewal, do you expect any discussion around results or changing models or different approaches that could get better outcomes for Canadians?
I think there is room for improvement. I think we see through these bilateral accords where monies are being provided for a range of issues, and including mental health and long-term care, and and digital-related issues. When they do these bilateral accords, there are outcome performance indicators. So I think that is positive. And I think it's we've also seen advancements, and Dr. Askari is actually, I think, part of those. When he was at Health Canada, we saw significant progress with the Canadian Institute of Health Information. I think now, all Canadians can go to these sorts of sites and see how we're doing province by province on these sorts of big issues, health outcomes, access issues, spending related issues. So I think we're in a much better position now than we were when Mostafa and I were at, Department of Finance in 1980. So I think that, it's, given the tightness of the fiscal situation, I think, and the need to kind of spend money wisely in this area, I think there'll be a push probably to do, a little bit more on the bilateral accord side where we see stronger performance indicators. I think, again, the more we talk about outcomes, the more I think politicians connect with Canadians.
Now, even a push towards bilateral approach, it still doesn't help provinces deal with the demographic pressures, which now are falling on them. The federal government has, I guess, to some extent insulated itself from some of the demographic pressures, fiscally made itself sustainable through a series of cuts and over the years. How do the provinces improve their fiscal sustainability while managing these pressures if the federal government is still going to kind of largely hold the line on the transfers and focus on kind of smaller bilateral issues?
Well, first of all, the government is not holding the line. I mean, it is actually growing over time. There is definitely demographic pressures, but those pressures actually over time, they're going to decline, because although the aging continues, but the rate of aging is going to decline after 2030-31, once the baby boomers exit the population. And then that you're going to see a little bit less pressure on those sort of expenses. There's no doubt that the aging is a big driver of the healthcare cost. And in fact, one of the things that have been always discussed in the past, and the government's never agreed to this, is that the allocation of Canada Health transfers should be based on the aging demographics of different provinces. Because right now we are doing an equal per capita allocation. And why that is equal but is not equitable, because the provinces like Newfoundland that have huge aging issues, the cost per person, health cost per person in those provinces are much higher than the cost per person in Ontario and Alberta or BC.
So, Kevin, how does this negotiation kind of play out when spending continues to rise faster, healthcare spending, than provincial government's fiscal capacity? How do you square the circle with the asks that are coming from the provinces with the fiscal kind of limits that the federal government currently has?
Yeah, I think there's definitely a feeling that the fiscal situation has changed since COVID. That I think Canada, other countries are experiencing much higher debt because of COVID and other factors, and I think the military as well is a huge fiscal pressure. I mean, if you look at these sort of budgetary deficits in different sizes of different countries, in Canada, our deficit, total government deficit, probably in the 2 percentage points of GDP, which is definitely higher than prior to COVID. So everybody's a little bit squeezed, in that sense. So I think the idea of getting, if we think of GDP as an indicator of the tax base, it's reasonable for the federal government to think about, we're going to grow the Canada Health transfers with, in line with GDP, which is, as Mostafa said, a 3-year moving average right now in the current agreement. that will fall into place naturally at the end of in 2028, 29. But then how can we work with provinces to adjust our system, in the context of a Canada Health Act, adjust the system on primary care, long-term care, other aspects of the care system, so that we're actually growing spending and achieving, I think, better outcomes. But moving, spending in line with GDP, in line with our tax base, so we're not building up more debt for future generations. So I think that's going to be, just the productivity of the healthcare industry. We have good outcomes. Canadians are very healthy and tend to be healthy when we look at OECD indicators. But our system definitely lags on access, the quality of care.
Yeah, no, you're right, Kevin. It is a big important thing, and there are issues with the service. In fact, when you have a market-based health system, the arbiter of the supply of demand is the price. When you have a public sector, you don't have that arbiter, the equilibrium the force to do that. So in fact, wait times replaces the price for that mechanism that brings the supply and demand together. Maybe not completely, but at least it sort of helps. Despite some of the problems with the system, I mean, you go around and if you have a major issues, they take care of you really well at the hospitals. And that's one of the reasons that we have a healthier population than the American, despite the fact that we spend a lot less.
If you look at the spending that goes on in that sector, like on the inputs and those sorts of things, I think it underscores it's a really important part of the sector that you want to get right. And, we look at some of our spending measures. We're a big spending country. We spend well above the OECD average, not as much as the Americans, but, certainly above the OECD. Like you look at the United States spends significantly more than us, probably 4 or 5 percentage points of GDP more. Their health outcomes are not as good as Canadians on average, and they don't live as long as we do.
There's an implicit trade-off between price as the rationing vehicle versus wait times.
Oh, absolutely.
And that's why I thought, wow, we don't have that discussion out there, right?
I think there's a price access trade-off, but there's some quality of care issues that we've got to work on as well. Even though there are some really good stories, like there's some stories out there that get picked up in the polling. People want improvement in the quality of care as well as access. So can we do more? Can we actually provide better quality care and increase spending in line with GDP? I think that'll be one big aspect of the healthcare discussion. I think with between the different levels of government and the health community.
I think Kevin is right. It's not the money if it grows with the GDP on average, that is fair enough. What you need also, in addition to that, some restructuring of the health system in Canada. Canada Health Act was done. It's a great act. It governs the whole system, but it may need to be modified, may need to be looked at again and see whether there are changes in that can be made to make it easier for provinces to deal with some of the pressures that they face right now. And if it's done through the Canada Health Act, it will be systematic across the nation. So all the changes that the provinces can make will be the same across the country. And that does not create these differences that, Alberta is doing it differently than Quebec, and Quebec is doing it differently than Ontario. So there are definitely some structural changes are needed to make sure that the healthcare is more efficient, the cost can be used actually in the right places, and that will help.
So we've seen the Canada Health Act in some ways as being this very rigid architecture, and yet experimentation goes on and it gets tolerated. Are you suggesting that maybe we have a window here to re-architect this thing and start to say that maybe we need to create some room for experimentation, and maybe not change the single payer or the public payer, but maybe the delivery itself can start to more, not just tolerate, but encourage a type of experimentation that at least has been taboo politically to say out loud, but we know goes on. We have a pretty large private component to healthcare in Canada already. And I think we sometimes maybe don't make the proper distinction between public funding and private delivery. And the reality is most of our doctors are private as it is. But we've created these taboos, and there is a suggestion here that maybe we need to make the experimentation official.
Yeah, no, absolutely. I think you're right. Doctors are private businesses. Laboratories are private businesses. We still have a private system in place. But as long as all the governments, all provincial governments somehow commit to the public health in general,
right,
but with some flexibilities that could be done through the Canada Health Act, and then allow them to deal with some of these specific issues through private sector and other ways that they can find.
So, Kevin, we've had the provinces kind of face fiscal sustainability issues kind of pre-COVID, but we had the federal government which had room. And now we're watching that room. We watched some of that disappear with COVID, and we're watching some of the new pressures owing to kind of geopolitical issues with the United States and elsewhere take away what remaining room the federal government has. So is there any choice other than to start to rethink the Canada Health Act, try to preserve the important principles of access and portability and those things, but maybe start to open up how healthcare is delivered in this country? The other interesting issue I find is that, when I lived in the United States, my employer paid my healthcare premiums, right? And here we're paying it personally, and a big part of it through the provincial governments, through our taxes. But certainly, if you want to make this a payroll tax, which is what it is in the United States, one of the most injurious types of taxation you could possibly have in an economy. As we're thinking about these different models, we might want to quickly take a step back and realize there's some really good attributes of the model we have, but it doesn't preclude us from thinking about, so how do you make it better?
Yeah,
right.
Make it better.
So maybe this is a chance, using the fiscal pressures, to say, hey, let's have this discussion. There are enough studies to demonstrate that, part of why our system is better or has been more efficient has been based on the single payer.
Yeah.
Not necessarily on the delivery side.
Yeah.
And yet, as you pointed out earlier, we are seeing privatized delivery. We see it all the time, right? I wonder if maybe we're having these discussions not out in the open because politicians view it as a taboo, but maybe we can be a lot more clear about, so what are the central tenets of our system that make it work? And why don't those be core to the Canada Health Act and reinforce those things about access that are probably more important?
Well, I think, see here, you did a very good job framing the hinge moment that we find ourselves. And maybe in some ways we've been kicking the can down the road. I think when one looks at what the provinces are trying to do over the past few years, they're trying to bring costs down. And we've seen year-over-year declines in overall healthcare spending, public healthcare spending. So I think, looking for those ways to adjust primary care, looking for those ways to build stronger work teams, using technology, using nurses, nurse practitioners in different ways. These things they're all being experimented with right now. Now, Mostafa has a much deeper understanding than I do as how this connects in a public-private system. We're about 70% public, 30% private. How does that really connect in a Canada Health Act? Do we need to open that up? Or can we continue to do the kind of experimentations here that you talk about? Because I think that is the hinge moment. Again, we're definitely in a place when you have an economy 10 times bigger than you, the biggest military in the world, talking about a 51st state. We definitely feel threatened in that sense. And we're going to have to deal with trade issues and defense issues. But I think healthcare we need to see it as it's definitely a very important social cohesion issue. And actually, when we have good health in this country and good healthcare service, we're a much stronger competitive economy as well. So I think thinking about it in those terms, and the kind of experimentations here that you talked about, I think it brings us to this. The healthcare needs to be front and center as part of a hinge moment agenda.
Yeah, it's hard to talk about a productive economy without individuals that are healthy, well educated, well trained, and looked after, whether in their families or as necessary by the state. I think the discussion is taking us to this place where, whether it's this year or next year, the next few budgets are going to be really pivotal for what healthcare starts to look like going forward. And the forces acting on Canada and our economic and fiscal situation are maybe going to force a discussion that should have happened a number of years ago, but but really the politics didn't allow for it. Your sense, Mostafa, are we at that moment?
Well, I think we are, but I think it's not really the job of the federal budget to deal with this. I think the first ministers have to really get together and figure out exactly how they're going to look at the different changes in the structure of the system beyond the money. Money is an issue, but money is not the whole thing. Definitely the changing of the escalator permanently to a higher level is quite dangerous fiscally for the federal government. And that should, in my view, that should not be considered. Maybe for a temporary 4 or 5 years, that's okay. But beyond that, this is going to be disastrous for fiscal sustainability at the federal level.
So the hinge moment is about Canada's sovereignty, its economy, and how we present ourselves to the world and how we protect ourselves and our identity. Healthcare clearly is an important part of this. And so I think for the next couple of years, not just this budget, as Mostafa says, but on an ongoing basis, we're going to end up talking about the role of healthcare. But also I think healthcare represents part of that competitive advantage that Canadians have in this hinge moment. It contributes us to being a healthy, well-trained, strong population, able to be a productive workforce. And so I think hopefully we have more of a discussion kind of going forward. For a service-oriented economy, the quality of our human capital really matters if we're going to be a competitive economy. So with that, I also want to invite our listeners and viewers to maybe suggest some questions in the comments that you want to see about some of the pre-budget topics that the 𝗕𝗿𝗏 can cover between now and October, November, whenever this budget happens, because we really are looking for input. What are your hot topics? What do you want us to cover? And particularly from an angle that kind of integrates the ideas with economic and fiscal constraints and considerations. We'll certainly give our 2 cents. Thank you for checking in from your holidays in Thunder Bay, Kevin. And we'll look forward to seeing you back in the office soon. Safe travels.
Miss you guys. See you next week.
Until next time, from the Politics of Money.